It's a very large number of presentations on new drugs and the correlation between new drugs and the mutation status. And of course this comes from the next generation sequencing data that can subclassify AML in these 8, 9 or 10 pathophysiological different techniques for development of AML, and of course all the new drugs that potentially target specific mutations. And then we cannot take one mutation at a time, because there's definitely a strong interaction between different mutations. We have known FLT3 and NPM1 for quite some time, but we also know that we have to consider DNMT3A and also IDH. So it's a quite new area that is developing now. It will at least change the way we run clinical trials, because we have to test these new drugs. There have been a lot of FLT3 inhibitors around, and some have failed, lestoronib, for instance, but last year's plenary session with midostaurin, of course, was a step forward. And then we have quizartinib, we have crenolinib, we have gilteritinib, almost. And those are quite, they are different as regards specificity and sensitivity. So we cannot draw all at one effect. So we have to test this, and FLT3 is a late occurring mutation, whereas the IDH mutations, they seem to be one of the early mutations. And of course that might be very relevant also with this inacidinib and ivosidenib, which has had very nice single drug activity in refractory patients with these mutations, which is very interesting. And then of course we want to know if that could be put in an earlier stage of the disease and in combination with other treatments. So we have a lot to do in the years to come.